So why did we pick this one? And I think I'm just going to start with that really emotive slide of, if you have ever been unfortunate enough to witness a child having a febrile seizure, maybe some of these words resonate with you. They're really ones that I've picked up from colleagues, from patients over the years. But actually, if you witness this, most people say to me as a clinician, God, I thought they were going to die. I've never been so frightened. And it just really also to validate that, it really hit home for me. This was way before I had children myself, and I'd working with a clinical colleague. And at that point in time, we were working in an A&E department that was right in the middle of town. And so often people would present with their child running through the door because you were just off the side. And I was particularly working a night shift, and one of my colleagues, who was probably one of the calmest people I've ever worked with over the years, he'd have seen other children have febrile convulsions, came running through the door. They only lived across the street, I think actually in a hospital accommodation, running through the door with his little girl, who now had finished having a seizure, but had had a seizure and he had just panicked. And I think that it really just showed me just how scary for the parent or for a child carer that moment is. So one of the things, to have a caveat now, really what we're hoping to do from this webinar is to help you to understand them. Actually, if you've come tonight hoping for the answer and the solution and the thing that's going to prevent you from ever seeing a febrile convulsion, that may well not happen, because actually they're almost impossible to prevent. But sometimes one of the best ways for us to manage situations is just to understand them a little bit better. And if we understand them a bit better, then they can help us to feel more comfortable. So we're going to run through what a febrile convulsion is. I'm going to think about some of those red flags, think about how you manage it, maybe how you can manage temperatures, and then I said, open it up for some questions. So for those who have heard the term but don't really know what it means, and so febrile convulsion, febrile fit, temperature fit, all the same thing. So we're talking about a child who suffers a convulsion, so shaking, irregular movement of the body at a time when they're also running a temperature. So these are really common. About 5% of all children will suffer from a febrile convulsion. So actually, if we put some context there, that's a lot of children. So that's why maybe you have heard the term before, you've seen it. And we'll break that down a little bit more. So about 5% of all children will suffer from a febrile convulsion at some point. So as we said, this is a seizure associated with fever, and our classification of fever currently in the UK is above 38 degrees. One of the things I really want us to think about, though, is I don't want hang-ups on what the number says, and we will come back to that, because one of the things that we need to really all understand is it's not about a magic number. And I think for a lot of people, we fear high temperatures, but actually it's not necessarily about the height, but we'll come back to that. And then what does it mean? So it's a brief. Now, classification of a simple seizure is under 15 minutes. Now, to me, 15 minutes is an incredibly long time. Please don't think that that's how long most of these last. They'll probably actually, most of the times you've seen a seizure, it's less than 5 minutes, 1 or 2 minutes. But in the moment, that feels very long. And it's generalized by what we term tonic-clonic. So that means tonic stiffening of the body. So people that have seen this may well have noticed that the child stiffens or they arch. And then we have the clonic bit. The clonic bit is the movement of the limbs. And what's quite important here is that it's the movement bilaterally. So it's the movement of all limbs. One of the things we're going to come back to, which would be not simple and maybe a little bit more worrying, is if the movement was only one side of the body. The other thing as well that helps us to define febrile convulsions is the age. So really, these can happen anywhere from 6 months to 6 years of age, but we can shorten that bracket. Most of the time, the child will be between about 12 to 30 months of age. So you might be unlucky enough to have experienced this in a child who's 5 or even just coming up to 6 years of age, but generally, we're in that lower bracket, so sort of under 3, we're between about 1 and 3 years old. Okay. So why do they happen? So we're going to have a little think about why they happen. If we're honest, we're not 100% certain about everything, but what we do know is that the bit of our body that controls temperature is the hypothalamus within the brain. That's the part of our body that sends those signals. So when you're cold and you shiver, or when you're hot and you sweat, that's been triggered by the hypothalamus. And in this group, so children under the age of 6, this isn't mature yet. It's still growing, it's still maturing. And what we believe happens is that the immature state just makes it really, really reactive and sensitive. So if the child's temperature jumps quickly, so over a short space of time, their temperature increases, that's when the child will potentially have this seizure. And we're going to really, probably more in the Q&A at the end, but focus on that, because actually a child can have a febrile convulsion at 38, 38.5 degrees, 39 degrees, 40 degrees, over 40 degrees. It's not the number, it's what was their temperature and how quickly did that temperature rise. And then in that immature brain, and it, as scary as it is, and I know I haven't laid down how frightening they are to witness, in the immature brain, it actually does what we want it to do. A febrile convulsion works. It helps to lower the child's temperature. But our brain gets a little bit overexcited and just reacts too quickly because it feels that sudden jump and doesn't know how to manage it. There's a couple of other things we are starting to know. So there is some more recent research that's beginning to suggest that potentially, so the first thing to say is this is not a genetic condition. So I don't want someone to read that and mistake it. But in some of the research that is examined and looked at, the children that are having febrile convulsions, and particularly some children that have had recurrent febrile convulsions, in a number of those, they have found a slight genetic mutation on the sodium ion channel and the neurotransmitter genes that potentially suggests that this change, this slight irregularity, makes their neurons even more sensitive, and that's what the reaction. Now, that doesn't particularly help you because, as I've said, it's not a condition as such, and therefore you wouldn't know that your child necessarily had it. But what it does do is it does help us a little bit to understand why potentially there is a pattern in a family. So again, it's not a blanket rule. If you've had one child that has a febrile convulsion, you won't necessarily have subsequent children that have a febrile convulsion. But actually, there is sometimes a pattern. So actually, there is some familial tendency, and we think that that may well be linked back to that gene. So we're just going to try and unpick a couple of the myths that go around with this and that add to the fear really around a febrile convulsion. So for most people, that first question is, so is this going to happen again? Is this something that I've got to keep dealing with? For about 30% of children, so about 30% of that 5%, so about 30% of children who have a febrile convulsion will go on to have a second one. But let's look at that also positively. That means 70% of children who have a febrile convulsion only ever have one, but about 30% will have a second one. Again, not super easy to predict who those will be, but some of the things that make you a little bit more susceptible to recurrent. The first one would be those children that are in that lower end of the bracket. So I said right at the beginning, 6 months to 6 years. So those children that do have their seizure before 18 months of age, within that first sort of year of this occurring, so 6 months to 18 months, if you have your first seizure that young, then you may well go on to have a subsequent one as your brain continues to mature and to develop. The next one is that if the child was one who had quite a short duration of illness. So what we mean by that is they actually seemed quite well. They hadn't seemed particularly unwell, and then they started to get unwell and very quickly had a seizure. So that's the ones that indicate that their neurons respond at the lower end at any sort of temperature jump. And then that third one that we've already touched on is potentially if you are a child that has a family, within the family is that history of seizures, you may well fall into that 30% bracket. Again, doesn't really help you to predict it. And I guess one of the things that I want to come from this conversation and the chat that we can have afterwards is really understanding that, sadly, with febrile convulsions, there's not magic. What I'm not going to be able to give you here is the magic answer that's going to tell you how you make sure that they don't happen, how you prevent them, because that's the bit that's really quite hard to do. If the child's brain is responsive and excitable to that sudden change in temperature and they're unwell and they've got a temperature, they may well have a febrile convulsion. Instead, what I hope happens from this conversation, and really for most of you, I think it will be just reiterating what you already knew, but having greater confidence with that. But what I'm really hoping that will help you to just understand what's going on. And if you understand it, then at least that can help to get you through those horrible couple of minutes, which if you are alone with your child, and if this is your child or a child that's been entrusted into your care, I can't make them not frightening. They will continue to be a little bit frightening, but it just helps you to understand what's going on and what it's not. So the other thing that really worries people is, now my child's had a febrile fit, does that mean that they're going to go on to have epilepsy? So again, a really important thing to reiterate here and to highlight is that they are different conditions. Now, what might happen is a child who is going to develop epilepsy, children will have seizures, children and adults, but with epilepsy, there are a number of triggers, and stress on the body is a trigger, and illness is a stress on the body. So sometimes people's first fits are when they're unwell, and therefore potentially are when they've got a temperature. But what I'm trying to highlight here is that they're really different conditions. So having a febrile convulsion absolutely does not mean that you're going to go on to have a seizure. It's a very, very small group of people that will have both of those things. Okay, so how are we going to manage it? This bit's sort of simple. This is in the moment, and many of you will know this off the back of your hands because you say it all the time, but others of you will have understood this and chatted about this when you've been on any sort of first aid course. So in the moment, let's describe again what you're going to see. So hopefully lasting no more than a couple of minutes, 5 minutes probably, but under 15 minutes, your child is going to potentially stiffen and shake all of their limbs. What often people will also describe is a rolling back of the eye, so it's a little bit frightening like that, and the child's not responding to you in this moment. They're going to breathe spontaneously when the seizure stops, so what we're going to do is just keep them safe in the moment. The safest place nearly always is the floor, so depending where the child is, if they're on a sofa and you can stay with them and protect them, or they're in a bed, you can stay by themselves, no need to move them, but you're just going to make sure that they stay safe during that seizure. So are they likely to bang their head? Are they likely to hit their limbs? Is there anything around that can be a hazard for them? If there is, can you pop something maybe underneath their head if they're on a hard surface, a pillow or a coat, or just not holding them, but just resting your hand underneath their head so that if their head's bumping, it won't hit against the floor. Once the seizure has ended, then what you're going to do is keep the child in a safe position. Now, we're not going to describe the recovery position. You don't necessarily need the full recovery position. The safest position is the child just laying gently on their side, may well be with you. If they're small, then that's absolutely fine for that to be baby in arms, you holding them, but in a position where their airway is naturally open. And if they were to vomit, and actually vomits and febrile convulsions aren't an automatic thing, so not necessarily going to vomit afterwards, but if they were going to vomit, it's not going to go back into their throat. We want to make sure that what you don't do though is that you don't particularly try to move them. Now, obviously, I just said that if they're in an unsafe place and you want to guide them to be still on the floor, that's moving, but what we mean is picking them up, taking them, going somewhere else. We want you to stay where you are in the safest position. But what we don't also want you to do is hold or restrain them. Their body will continue to jerk under your hand. So if you're holding them or forcing them in a position, you're actually more likely to injure them. So just ensure that there's nothing for them to hit or bang into. Again, a couple of things that were historical. So this carries on for fits, whether it's from a febrile convulsion or a different cause. Do not put anything into their mouth. Now, you may be aware that it's quite common to bite the tongue when you have a seizure, less likely in febrile convulsions than epileptic fits, but someone might well bite their tongue. But biting a tongue is a small consequence of this occurrence. Putting something into their mouth that's going to injure them, knock a tooth, cause an airway obstruction, all sorts of other concerns can be far worse. The other thing that I don't want you to panic about doing at that moment is worrying about trying to get them cold. And we're going to talk about how you manage fevers, but particularly we don't want you lowering their temperature at the time, putting water on them, sponging them. So we're just sadly going to ride this moment. And I know that one of the things that isn't going away is the fact that you've got to watch it. So I touched on this earlier on, and really what I hope will come from this is a reduction in some fear for some of you of temperatures. So we really believe that, the most common myth is, I mustn't let the temperature hit this number, that my child is hot, maybe they've had a seizure before, and I've got to get the temperature down. Sadly, if your child's brain works in the way that it's going to be responsive and they are going to have a fit, there is very, very little anyone can do to prevent it. We can manage it, but we can't prevent it. So actually that change in temperature isn't necessarily going to stop them. So what I want you to think about when you're looking after children with temperatures is, actually, I'm not managing the temperature to prevent the fit. I'm managing the temperature because they don't feel very well. So we really want you to think about, actually, temperatures are a positive bodily response to illness. They are useful. They are useful at helping us to heal. They're useful to help us to manage, but sometimes we feel pretty rotten with the temperature. If your child feels rotten, if your child is quiet, this is one that we're just going to touch on, but actually one of the webinars we've got coming up is really looking at, how do I know when my child's unwell, and how do I manage it? What we want you to do is manage symptoms, not manage the temperature itself. So, of course, if your child looks unwell and is enjoying to have just a light fan around them or the window open, depending what time of year it is, they feel like they've got complaining of a headache or toothache, or they're just irritable. So if we think about the age group, they may not be able to tell you what's wrong, they just are not happy, then by all means treat them with what's referred to as an antipyretic, so the medication that can help to bring their temperature down. So for most of you, that will be Brufen, so Nurofen, or paracetamol. But we should really be focusing on not trying to fix the temperature, but sort the symptoms. How does the child feel? So we've got some other general tips here for managing temperature, and I've just seen our little emoji of a chicken, which I will explain in a second, but we're hoping will help you to remember it. So one of the first things to think about is, actually, when the child has a temperature, cool, loose clothing is ideal. Actually, we also don't want their temperature to drop too low too quickly either. So we just want slow, steady change of temperature. So dress for how they feel comfortable. So generally that's light, loose clothing. Fluids. This will come up in any seminar we do, any webinar we do about unwell children. Actually, the most important thing is our children stay comfortable and hydrated. We don't need to worry about food. Let them pick, let them choose what they want. We can all last for a very long time without very much food, but actually what we really want is fluid. But fluid input and fluid output is one of those things that we'll definitely come back to again on the second seminar. just thinking about actually keeping our children hydrated. So this will help the brain to trigger those natural responses to temperature control. So fluid's really, really important. Antipyretics, I've said, so there's absolutely no problem you giving your child something to help them bring their temperature down if they're presenting as an unwell child. And then this has nothing to do with febrile convulsions, but it was a really good opportunity for us to put that little side note in, just because we've got a good wide audience of childcare workers here, is that if you weren't aware of it and you've never heard of it, chickenpox is the one exception. So I've talked about using paracetamol and ibuprofen. Both of those are really good medications for helping a child who feels unwell to feel better, safe, over the counter, as long as you're following the instructions and giving the prescribed dose. Really useful medications for you to have in your medicine cabinet. I know some of you as child carers may not be able to administer, but those two are really, really useful. But one of the messages that we need to get out more widely is to not use ibuprofen. So Nurofen, I'm not using the brand name, but most people are aware of the brand name, so it's really helpful. Ibuprofen when you have chickenpox. And the rationale for this is, again, we're not 100% certain of all of the reasons why, but ibuprofen has been linked to really quite nasty bacterial skin infections with children who already have chickenpox, so a break within the skin. Okay. One of the other things you'll notice that we haven't got there is we're not encouraging you to lower the child's temperature with tepid sponging or the overuse of fans directly on a child. There really is no evidence that either of those help with temperature reduction, but actually what they are more likely to do is vasoconstrict, so cause the capillaries to shut down, centrally move our blood supply inwards, and actually that's going to have the adverse effect of raising the child's temperature. So what we want you to do is not overly cool. You'll see that actually nowhere anymore is tepid sponging or cool water and fanning advice that is given. Okay, so we want to just think about, I've said that the seizure, and one of the things that is most definitely, and I'm very aware I've got, I think, at least one, if not two of my paramedic colleagues on the call, and our emergency services are under a lot of pressure, but we are never wanting you, if you are frightened, if you're worried, and I've never come across a paramedic who wouldn't understand being called to a child with a seizure. But if this is something you're managing, if this is your child's second or third seizure, you might be calmer and not necessarily feel you need to call an ambulance. So on top of all of these things, if you're frightened, if you are worried, you can always still call 999 for advice if a child is unwell and you think that something is wrong. However, in these three occurrences, we want you to ensure that you definitely get immediate help. So if this is the child's first seizure, you won't really know much about it. You won't know whether this is a normal febrile convulsion. It's quite likely actually nowadays that you'll just be seen, you'll be reviewed, and you won't necessarily even need to stay in hospital. But you should go to hospital, and by hospital, I do mean to an emergency department, with a child who has a first seizure. The next group of children who must always be seen is when we come out of the bracket of simple into complex. So what do we mean by complex? So complex is that the seizure is lasting for more than 15 minutes. 15 minutes is a very long time, so I'm quite sure many of you would have become more responsive after probably about 5 or 6 minutes. Most of these seizures are 1, 2, 3, 4, less than 5 minutes. But if it lasts for more than 15 minutes, you must call an ambulance, and you're probably going to have called it after about 5. So after about 5 minutes, then consider actually this, maybe I'm a little bit out of the norm here. If the child has one seizure, it stops quite quickly, even if this is a child that's had previous febrile convulsions, so you're not in that first seizure bracket. If the child has one seizure and it stops, but within that 24-hour period, they have another one, it's often actually quite close together. So if they're having recurrent seizures, then they must go to an A&E department. And that last one is if their seizure, so I said to you at the beginning that they would have a tonic-clonic seizure, and the clonic bit being the moving of all of the limbs. If this seizure is only affecting one side of the body, then again, that's one of the things that must be seen. And last but not least is a child under 18 months. So I have said that these do happen from 6 months onwards, but they are rarer in that younger age group. They're much more common in that 18 months to 30 months bracket. So if it's under 18 months, and particularly because those children are much harder for us to communicate with and to pick up other problems. So if your child, even if it's not the first seizure, if the child's under 18 months, then the current guidance is still that you should seek advice and be seen in hospital. As I said, with those, if you are worried outside of that bracket, you are still absolutely right to gain some advice. But these are the ones where actually, if you've managed to get used to febrile convulsions, if this is something, so I'm thinking there may well be a parent on the call who unfortunately does have this as a common occurrence amongst your children, maybe one of the second or third or more, second or third child to have a seizure. This isn't their first, so normally you would be quite calm. What we really want you to think about is it definitely in that simple definition? And is the child definitely over the age of 18 months? Okay. Also, some things for you really to think about post-seizure. So I think these are slightly different. And these are maybe where our underlying problems. So for many children who have their febrile convulsion, they've got the underlying cause is something relatively benign. So we do all get unwell. We get unwell all the time. The majority of the times it will be a standard viral illness. However, there's obviously some things, and we're going to really explore this in the second webinar and actually being able to help you think about, how do I know when ill is properly ill? How do I know when I should be worried about my child? Because children do get unwell. How do I know that this is different? And that's going to be the focus of a webinar coming up. But associated with seizures, what we also want you to think about is actually the child's had a seizure. Now, following a seizure, and a febrile seizure that we're considering here as opposed to epilepsy, the child will be sleepy immediately afterwards, but they should be rousable. And within that first hour, they will become more awake and become more normal and become more active again. And usually, actually, 10, 15 minutes following a seizure, the child is far more back to their normal self. We want you to, again, really be concerned about, and again, seek medical advice if your child is hard to wake. So after the seizure, actually, if they're stopped shaking but they're really not waking up very well, then we would want you to consider calling 999 again. If the child is still quite sleepy, so they're easily rousable but they're just not themselves an hour after the seizure, then we're starting to question, is there something else that's going on here? Thinking about the fact that seizures are associated with the brain, one of our concerns there is to make sure that we're not missing children with potentially with meningitis. So we're thinking then about the rash that doesn't fade. Sure, this is one you're all very familiar with, but either you would press a glass, I should have had one with me really, a glass against the skin, and you're looking through the glass, you're putting pressure against the capillaries is really what we're trying to do here. We're pushing the blood out of the capillaries, and for most of the time that will go away. Normal viral rashes, heat rashes, that will all disappear. But if you've got a rash that doesn't disappear, obviously we want you to be seen. If your child is just not yourself, so one of the real things about children is behaviour. Is there something that's making you think this is just more inconsolable than usual? I always have this thing about, many of you might be far better parents than me, and that those of you that are carers of children will be spot on with this, but I can remember that feeling as a new mum, thinking, well, everyone says that cry is a pain cry, that cry is a hungry cry, that cry is a nappy change cry. If I'm brutally honest, I never knew the difference between any cry. I knew that it was probably a nappy change because I hadn't done it, or it was a food hungry cry because they hadn't been fed. The cry of pain, though, is very, very different, and very much to a parent or a carer, that's that I've not heard, this is not their normal cry. This is different. For the clinicians that are on the call, I'm sure a lot of you, like myself, I can walk through a children's A&E department and tell you that there's a child in a cubicle just by the pitch and the tone of their cry. So one of the things I want you to think about is just if you're thinking, this is just not them, I can't settle them, and I'd normally be able to settle them, or their behaviour, so in the older child, their behaviour is a bit unusual, then that's one of the things that we want you to think about. Not liking the lights is fairly classic. It's not seen actually that often, so it's not a great one to hang on to, but it's one to note. And then that last one we've got there is stiffness of the neck. And I really want to emphasize here, this is stiffness. So children, you often ask them, how do you feel? And they'll say, oh, my neck's sore. Neck sore is a sore throat, or my neck hurts. My neck doesn't feel right. That's a sore throat. So again, just gently ask them to move their head around. If you're getting the picture of someone who looks like just come out of a car accident, then that's a stiff neck. It's very different. It's not a sore neck. It's a stiff. It's movement that they're not liking. Okay. So the last couple, looks like I've still got loads, but I really haven't. Now, I find this one quite an interesting one. We purposely kept this photo on the slide because what I don't want you to do is worry about temperatures, as in a number. But when you look things up and you look at national advice, you will see that actually you do have markers. So our guidance is a temperature of, so here we want you to seek medical advice, but this isn't necessarily 999. This is much more likely that, can you see your GP? I know that that can be a challenge in some areas. Can you call 111? So you can do that everywhere. Do you have a local urgent treatment centre or other minor injury, minor illness, really? So most minor injury units won't see young children, but do you have an urgent treatment centre, your own GP, or can you call 111 just for some advice? So what that's really saying is any child under 3 months that you think has a temperature, whether you've recorded it and it's above 38 or they just suddenly feel really quite hot and are not happy, must be seen. The children under that age, particularly bacterial infections, will worsen much more quickly, are harder to manage. There can be a number of reasons why they're unwell, and we really want them to be seen carefully. They obviously can't tell us anything. We can go a little bit hotter in a child from 3 to 6 months, but we want to know the underlying cause. Again, any children's infection under 6 months. So if you're worried about a child at temperature of 39, it is worth at least seeking advice from 111. Is this a temperature that's just not going away? So you're managing it. One of the things I think there is, if the child's older and the whole family is unwell and you're staging it and you're all slowly starting to get better, then you don't necessarily, you've got a reason for your illness. But if you've got a temperature that's really not going after 5 days, it is absolutely valid for you to want to get some advice. If the child's not their usual self or you're worried, and I really would hang on to that as much as, and I'm currently working in a number of different urgent treatment centres, and many of the reasons people present are because they're concerned, and it is a valid reason to present. If you think your child's not themselves, then always come. And then that last one that we've already just mentioned earlier is around dehydration. So if your child's not drinking, if you're noticing that their nappies are a lot drier or they're not weeing as often, then that's a real reason why we want you to seek help. Okay, so I'm going to stop sharing now. And I probably haven't done too badly on time. So yeah, that's right, 40. So I'm going to stop sharing. If you then, we haven't got anything in the chat yet, but if anyone does have any questions, wants anything to ask, so it was really that aim while we're looking to see if anything comes up. And if anyone feels brave enough, please do click the raise your hand, and Tina has to do something fancy to allow you to come on the call. But what we really wanted you to think about, probably for most of you, that was information that you already knew, but it's about re-emphasizing some of those take-home messages. So my real take-home messages here are, it's not about the height of the temperature, it's about the jump. So it's not how high does it go, it's how quickly does it go, which unfortunately means it is hard for you necessarily to stop it. But what we do want you to do is understand it. So, sorry, Jamie, thank you. So I'm going to read this question out because I'm not sure anyone would, I'm not sure if all of you can see it. So Jamie, if you're happy, I'll repeat that out live. So what's the best practice for a child who appears well and then suddenly has a febrile convulsion? Should we have anything particular in their care plan? So I think by this, and it's always quite hard when you're typing it, so do raise your hand if you're happy to chat. The problem with that is, so I think what you're saying is, should you have anything particular, as they were the group that I highlighted, who may well be more likely to have a second convulsion? I think the thing that really I'm trying to emphasize, and I know is horrid, is there's very little that you can do to prevent that, even for that child. So this would be, and I can particularly think of a particular family that I nursed for quite a while, and they did come in with each one, and I completely understood why they come in with each one. This child would be generally pretty well. But at the start of any illness or infection, as soon as they started to peak any sort of temperature, they would have a fit. So I don't know what you could put into a care plan that would enable you to protect that. But what I would say is, what you need to ensure as an early years setting is that your staff are comfortable and happy and aware of those children. So probably very similarly to having a child who has allergies, or having a child that has any other problem. It's about thinking about where that child is, maybe being as hypervigilant as you can about just changes in behaviour. So what would have happened with that child is they would have become more quiet. They would have become a little bit more withdrawn. But the thing is, you can't. So this is a child who's not going to, example you're giving me is a child who isn't going to particularly look unwell. You couldn't send home because there'd be no real reason. So what's really hard there is I can't give you a brilliant answer with that one, because the whole point is, what I'm saying is, they're quite hard to predict. Oh, we have got quite a few more. Hold on. Let me scroll down the page. Yes, Alan. So the question here, are we saying do not try to reduce the temperature once the convulsion has started? So absolutely, in the moment of a convulsion, we should not be reducing a temperature. The only way we would be able to reduce the temperature during a convulsion would be with tepid sponging or fanning. And both of those are not recommended currently. After the temperature, as soon as your child is more awake and rousable, then absolutely, if the child is irritable and once they are awake enough to swallow and can take medication, then there's absolutely no problem giving an antipyretic. And I think probably for most of you, a child who has a temperature then has a convulsion, you're going to want that temperature to come down. But yeah, once a convulsion has started, we do not need to worry about trying. And even if you think about the practicalities of trying to undress them, that's really, really hard. I know you know this, but trying to then remember that this convulsion should last only a few minutes. Sorry, now you just needed one of you to be brave enough to, or maybe it was the speed of everyone typing, so we suddenly got a little flurry. So hold on. And if the answer doesn't answer it, then do come back on there. So parent, they should be seeking medical help based on the rent. Oh, so Pat, I'm going to guess your question is coming from the perspective of a carer. So the question, a really good question. If you advise a parent that they should be seeking medical help based on these flags, but they do not take your advice, how do you go from there? Great question. A tricky question, probably sends a little cascade of thoughts amongst those of you whose this is your professional responsibility, because we've got a couple of questions there really. Have they given you a really good rationale to why? So actually, to remind them of what the red flags are and see what the reason is. If they are medical, if they have a number of children who have febrile convulsions, they might give you a reason. Your responsibility is to share that advice and to guide a parent. Ultimately, the parent does have the right to choose, but then you're in that position. And really, for me, this triggers, how does the parent respond? Do they understand you? And is your concern that they are neglectfully choosing to not act? And if that's the case, then you need to consider your own safeguarding processes. And this is one of those classic ones where I think probably actually you need to bounce that idea around. Has the parent given you a reason? What was their guidance? But ultimately, as a carer, and this is the same thing, they can ring me up in A&E, they can walk into a urgent treatment centre, I can see the child and I can say, I think you need to go to A&E, but ultimately I can't necessarily make them, and I need to think about how much of a concern I've got about their care. Sasha, yes, but I don't know the answer to how. But Tina, the question here, can you see that one, is you lost half of it. This will be available to you to answer. Great question, Beth, on which do I think is better, and I'm not sure it's worth my job to treat a temperature. Do I think Calpol or Nurofen? What I will say with that is that they act differently, and this is not meant in a patronizing way, but very simplistic. The way paracetamol works is telling our brain that we're no longer in pain and unhappy. It does also lower your temperature. So I actually wouldn't think about them for a temperature. I'd think about them for what else am I treating it for. You'll also find certain children just respond better to paracetamol or to Nurofen. So there are certain conditions that are better with Nurofen. Throat, ear problems often are much better with Nurofen because they have an anti-inflammatory. So things that cause pressure, particularly in your ears or in your throat, the child may well. So it's not so much about, I don't think either is better for temperature. They're both antipyretics, and it will depend on each individual child which is better. But as in symptomatically, Nurofen is often better for anything that's likely to be pressurized. But it is really just a case of seeing which, and it's not because I'm choosing not to go with Calpol or Nurofen. It's more that each drug has its merit and will be different in how it responds. Probably if you went and asked all of your group of friends as adults, who takes paracetamol, who takes aspirin, who takes Nurofen for a headache, all of you will be different, and it will be which one responds better to your body. So really good question, Tiffany. And what I'm going to say here is, if it is your organizational policy, I'm not disagreeing with it. But your question was, would checking a child's temperature at certain times throughout the day be helpful? It would be helpful from the perspective of keeping you happy and calm. But my point really here is there is no magic temperature. So what it does do, and I assume, so I assume you're meaning checking every child's temperature. Actually, before you're flagging on a thermometer, I would expect you to be able to pick up things in behavior, in how they are. And I know it's not necessarily helpful. So one of the things I just said I'd mention, I'll mention it very quickly, is the webinars we've got coming up planning. So the next one is, how do I know when is unwell? And we're really going to start unpicking that even more, because I'm conscious that we won't have a lot of time today. We're then going to have a session where we've got an expert burns and plastic specialist talking, and I think we've got another one planned on choking. More will be coming. But what I'd say in that one is, no, I wouldn't check temperature. What you don't need to do is become paranoid about temperature, because what's going to then happen is the child whose temperature jumped quickly within an hour, you'd have to be, walking around with literal temperature gauges on your children all the time if that's how we're thinking, and it's not practical. But what I would do is think about, our behaviour's changed. That child's not being themselves. That child's suddenly a bit quieter. Maybe I don't think they feel hot, but I'm just going to check their temperature. But I'll go back to the point of, then it's so what? But what it might do is help you to say, oh, okay, they are coming down with something, they need to go home. Right, hang on. Procedure when their child's body is not. Oh, okay. So I'm presuming, so thankfully, thank you for that one. And sorry, not sure if it's Rob or Roshni or both of you together. So here, potentially, and I would need a little bit more information probably here. So your question is about a seizure where the child's just some face twitches. Now, we could have two things going on here. So what I really need to know with that one is your child responsive or not in the occasion? So this sounds more like a different sort, so absences or tics. And seizures associated with those which are not necessarily associated with the seizure, with a temperature. So I'd need to know a little bit more about that one. And so when do you class the end of an episode? Yeah, this depends on whether your child is responsive or not at the time in order to be able to answer that. You're saying that when they come round, so I think what you're saying is a child who stiffens, doesn't really have the full shaking, but is unresponsive. And then absolutely, yes, that's the point at which you notice that your child will respond to you. So one of the things we'll talk about in first aid courses and when we're talking to you is about the classification of unconsciousness. So unconsciousness is when a child won't respond either to voice or gentle painful stimulus, so tapping of the shoulder. So your timing for your occurrence, but it is quite hard without knowing a little bit more of the specific detail. But if what you're saying is the child is unresponsible, they're stiff, but it's really only their face that moves, and definitely if this is also associated with a temperature, yes, at the point, measure it to when your child will then start to move normally or respond to you. That was a thank you. Just had their first febrile convulsion at home, and then a second, oh dear, on arrival at the hospital, lasted 5 minutes, now been administered medication. Yes, okay. If this happens again, could you give me some more information on this? Okay, so again, really hard to be general. I don't know the specifics of this occurrence, but what I expect you have got, so that was quite unlucky. That child had a seizure, and then, so if you remember, we started to say a little bit more complex when it's more than one in a short space of time. And I don't know how old that child is, but what you will have been given is a medication that you've literally put inside the cheek if the fit continues. So what they provided you with is something to help stop the fit. I'm sure you've also been told, so I'm going to guess it may well be buccal midazolam, it may be something else, but what I expect you've been told as well is, so for this child, how you manage it is still the same. It's about that safe environment, but what you do have that most other people don't have is something that will prevent the seizure from happening. One of the things you need to be aware with that, though, is that you're giving a sedative in effect. So you're stopping the fit, but you're going to make that child very sleepy. So this is a child who afterwards, so if you need to give the buccal midazolam, I would advise you to be calling an ambulance as well and getting reviewed, especially if they're in that scenario. At least at the moment, what might happen with this child is I'm going to presume that they're under a paediatrician or a neurologist, and we're going to be looking at having a more detailed plan. You're still quite early on in their investigation stage. So you've been given this medication probably while investigations are still happening. So you've been given this medication because they've had a fit that lasted longer than 5 minutes to help you stop the fit. So that's what the medication is for. But it will work, it will stop the fit, but it will make that child very, very sleepy. So this is one where, and I'm going to hope, because it sounds very much like you've been in a medical environment, that you'll have done one of our sort of first aid courses, or you'll have done a first aid course, and they'll have first aiders there. This is when you need to really think about that child after the midazolam needs to be with someone with them all the time and nursed on their side. But the real difference is they'll be responsive to you. They'll just be really sleepy afterwards. So to ensure that their airways open and that they're comfortable lying on their side. Again, if that doesn't answer that, Vicky, do come back. So Rob Rushney, the question here, what I'm just a little bit concerned with your questions is just clarifying that these are also associated with a temperature, because a couple of both of your two questions could potentially be different reasons for a seizure, so could be more related to neurological investigations to check that that this child, and I'm guessing that this is your own child rather than one you look after, that your child hasn't got a different neurological problem. So we're looking more along the concerns and needing exclusion of epilepsy. But if the child is hot, then they could well be in that bracket of the quick jump. So febrile convulsions, so you might be aware that with people who have epilepsy, once they've developed epilepsy and they're used to it, often have something that we refer to as an aura. So an aura is where something will happen. It might be a smell, it might be a taste, it might be a feeling, where they know that something is about to happen. That is different to febrile convulsions. So though that group often do have warning signs. Febrile convulsions often don't have warning signs other than that they're unwell. Again, I'm not sure if that's quite answering yours, and do pop a note in the bottom if not, and we can definitely come back to you outside of this if necessary. If a child has had 3 febrile convulsions and the last one there were no signs of having a temperature before it happened. Yeah, so no, Jamie, I'm with you on that one. And so excessive is a really interesting word. So you have got the sort of child that fits into that bracket that are really, really hard to see, because they just, and this is the perfect example of why it's not about the height. This child you're referring to, who's had 3 febrile convulsions with no warning signs and not particularly known, playing happily before, sits in that bracket. And I don't know how old they are, because they're in that group of children, they're in that 30% that are going to keep having them. Not, you might be done, but potentially could. You're quite right, checking the temperature twice daily doesn't really make any difference, because you've got to literally be checking their temperature every half an hour for you to notice, and you can't live your life like that. However, what you probably do find is that people are now anxious and scared around this child, so it is making staff feel better. But what I wouldn't want to happen is that you've created a situation, not you personally, but a situation has been created where if someone was half an hour late to check a temperature and then the child had a seizure, they haven't caused it. That was going to happen. I'm not sure, again, if that helps, and by all means do have a chat. I want to try and get through the last few. We've still got lots. Yeah, I think in the same way as in your, and I'm guessing, Jamie, yours is a nursery, in your environment, you know that you will have children who have conditions and something might happen. The best way for you to manage that situation is instead just be really, really, really comfortable and sure that everyone knows how to look after a convulsion. And this is not at all a plug for Safe and Sound or doing anything, but you know, there are things, Safe and Sound would be one, that if you wanted to contact us and ask to have a specific session in your nursery or on, you know, I've recently done one on anaphylaxis, particular anaphylaxis, because there was a high number of children. The way you manage that scenario has to just be to all be really confident in managing a seizure. You just keep taking the temperature isn't going to stop it happening. But I think you sort of, by the way you've worded that question, I sort of think that's how you feel too. But how can we differentiate from other medical emergencies such as choking or fainting? Okay, so the real difference with the febrile convulsion is the presenting. So choking is well, as long as you are with the child at the point of choking, they will initially be responsive to you and conscious, looking at you, eyes open and aware. Fainting is unconscious, but we haven't got the shaking. So what you're really looking for with a convulsion is that tonic-clonic that we've described. So arching of the body, stiffening of the body, not responsive, and that shaking. So a faint, not responsive, but breathing and not moving in any way. So their body won't be shaking in any way. Choking is different in that in the first stages of choking, you are awake and you are conscious and you are responding. Again, I'm not sure if that quite answers that. Rob and Roshni, I think we've had a couple of jumps through. So we know that yours is now. Thank you. I think we've got there because we're jumping around. So I think you've answered, but in summary, zero signs. Well, playing capital. Yeah. So actually, Rob and Roshni will comment, and back to where have I lost you? Jamie's comment. It does sound like, and I totally understand, one, why you've come to the call, and two, why there's some anxiety about it. You've got that little group that we talked about right at the beginning who their brain is in that super sensitive, hyper responsive state. So for them, and the worst thing about being early years is they've got to just grow out of this. And so again, that same, all our settings, children are children. Yeah. So, and it is really, really hard. And the one bit I'm not trying to dismiss with any of this is how scary it is. It's just to understand that it's a natural bodily response that will, as their brain develops, when they become 6 years old, will stop. I am conscious of the time. I'm actually all right to hang on, making sure oh, it's only one more. No, really good question coming right at the end, and I don't want to miss it. Jess, no, febrile convulsions do not cause brain damage, and it's a common myth. So febrile convulsion is the brain responding in a natural way, but in an immature tantrum way. If we wanted to put this into a term we understood, a febrile convulsion really is the hypothalamus having a tantrum. So we'll leave it on, quite enough. So very scary for us to watch, but it's the hypothalamus being reactive. So a standard febrile convulsion, a simple febrile convulsion, there is no reason, hence why you will also know behavior should be perfectly normal afterwards. If the child's behavior is different after a period of time after the convulsion, then they should be being seen and reviewed to see if there's any other difference or cause. But no, there is no evidence that febrile convulsions cause brain damage. We'll let you all drop off and enjoy your evening, but we are really grateful. We didn't have faith that the number signing up would attend, but I think we got to nearly 60 in the end, so it's really, really appreciated.